So I'll just introduce you, Sharon. Thank you everyone for coming. Today we've got a special guest, Sharon Kay, who's talked for us before. She's a extremely experienced echo educator. And not to go through your whole CV because I wouldn't stand a chance, but she's a cardiac physiologist and professor in cardiac imaging, and is currently teaching in the Mayo Clinic in the US, but started Australia's first undergraduate cardiac physiology bachelor's program. She's a lecturer with interest in cardiotoxicity, amongst others, the founder of Structural Heart Disease Australia. The list kind of goes on. So it's a real pleasure to have you here teaching us. A very big privilege. So I'm going to hand over to you. I'll put my mic on silent. Just tell people if you want them to interact.
Okay, cool. So what I'm going to start with today is we're going to go through two parts. So cardiac oncology, if you look at the American, Canadian, and in Europe now, what they believe is cardiotoxicity is going to become one of the biggest within the next 5 years, maybe a bit more into 8 years, is going to become one of the biggest causes of heart failure out of any type of pathology. Due to the nature of the agents that we're using, also during the nature of the personalization of oncology treatment and agents, and the newer agents coming through, especially the immunotherapy agents. But what I want to talk about is mainly how it can affect you in intensive care or pre-operatively in the pre-anesthetic clinics. So first, we're going to go through a few of the cardiotoxic effects, and then mainly myocarditis, because that's going to be the one that's going to probably affect you and slip you up the most. And then we're going to go through the major masses, what they look like, and what ones that you do have to act on, and what ones you can just leave alone, even though they may look bright and shiny. So what I want to go through is mainly if we just move to the cardiotoxic effects. So cardiotoxicity is when an agent or any sort of pharmacological agent affects the heart. So let's just say it's just affecting the heart only. There's a lot of different reasons that cardiotoxicity oncology agents can affect the heart. And the reason that we want to look at them individually is because they all do very, very different things. So there is a bit of a trade-off. Is it going to kill the cancer or the oncology masses, or is it going to affect the heart, and how long is the patient going to live for, and can they tolerate it? So what we want to really make sure of is we want to make sure we always follow just the basic principles of reporting and looking at bedside cardiac ultrasound. And as you know, I never call it echo because an echo is a full interrogation and a bedside cardiac ultrasound is a look and see. So what we're going to have a look at here is previously, I'll just go to the next slide, then I'll come back to this one. Previously, what would have happened, and I'm sure you have some maybe older consultants, is basically if a patient's heart was really badly LV function and they previously had chemotherapy, which obviously can include a lot of different things, we're going to blame the chemo. The chemo caused the LV dysfunction. The chemo caused the constriction. The chemo caused it all. That's no longer the case. So the drug that they were talking about, or the set of drugs that they were talking about, were anthracyclines. And anthracyclines were used heavily. They're used heavily in children, and they were used heavily to just get rid of most of the cancers that we could have. That's no longer the case. It's very, very tailored. So what we need to look for is previous oncology agent conundrum. So what we want to look for is first the what. So what is being caused? Is it a mass? Is it LV-RV function? Is it fluid within or around the heart or in a pocket? Or is it thickening of the valves? Okay. Then we have to look at when. When did they have the agent? Is it acute? Is it 3 weeks post? Is it 6 months post? Is it 10 years post? Because these different time points and time stamps tell you if it could or could not be the cardiac oncology agent that was given, the oncology agent that was given. Then we want to look, where is it? So is it in the heart? Is it on a valve or on a wall, or is it around the heart? What exact agents were used? Dosing, what dosing was used? Were they using underdosing? Were they using traditional treatment dosing? Or have they overdosed or given an over lifetime expectancy of the dose to treat the cancers? And most of these will be renal cell carcinomas. And if it's actually affecting anything now, or if it's not for an intensivist really to worry about, and it's a cardiologist that needs to go forward. Just changing the slide, and hopefully you can see this. So What we don't want to do in the current world of looking at cardiotoxicity is previous chemo should not be an automatic clinical slide that's why the left ventricle is down. Because this, as I've said before, was caused by anthracycline therapy and mostly, to be honest, mitoxantrone. So what we have to do is we have to take that out of our repertoire when we're dealing with people that have had chemotherapy. Chemotherapy is incredibly tailored now. Oncology treatment is incredibly tailored, and also the dosings are incredibly tailored. So we have to really be a doctor and a clinician and go through and find the information before we make wild assumptions. Okay. The what? Is it valvular or is it ventricular? These are sort of the two things that oncology agents will cause problems in the heart. Ventricular, it could cause reduction in left ventricular or right ventricular function. It can also cause a type B failure, which I'll go through with global longitudinal strain, which means that there is failure happening, but it won't be apparent in the normal state of a patient. But if the patient is put at stress, which could be within ICU, then it will become apparent. The other one is valvular function. Okay, so valvular function can be caused by things like sinistrib or sutent, anything to do with infiltrative diseases, sarcoid, carcinoid, things like that. So that can actually then also cause some sort of infiltration within the semilunar valves, mainly the aortic, and this treatment can then cause aortic stenosis, which actually will look like sclerosis on the echo. Okay, so we want to go back to our very basics. So let's just do a very quick thing. So I'm just going you a few shiny objects. Now, this is an absolute rookie error when looking at echo. So I know that you're probably all beyond all of this now, and we don't follow shiny objects. We follow a protocol. Basically, when you see a huge effusion, that's always the first one in your first learning echo. People run for those when we should just use them, look at them last. The other thing is masses. Don't jump to the mass and follow the mass and forget everything else you have to look at in the heart. Okay, these things patients can live with or have lived with for a long, long period of time. So they may not be causing any problems in the here and now. So what I try to teach all of even my cardiologists, my physiologists and intensivists is don't get distracted by shiny objects. Don't go put an echo probe on and see these things moving around within the heart and go, oh my God, we've got to do something about this. We've got to then go and find out what this is. We've got to look at it. We've got to find out where it's coming from. Stop, take a step back, go through your protocol. Okay, so let's just go through this. Let's just do a very, very quick revision on how we analyze and look at images, and so that we don't go forward and follow shiny objects. Shiny objects are either masses or pericardial effusions. We're going to go with a very quick stick approach. This is how we analyze an image. We look at the size of every image, anything that's black. Is it pulmonary systemic, right or left? Okay. Thickness is a very standard protocol to look at all images. Thickness. Is it thick? Is it bright? Therefore, is it chronic or acute, old or new? Function. Is it doing what it's meant to do? Is it opening? Is it shutting? Is it squeezing? Is it augmenting? Is it, and we never use the words with function, as you all know, but I'm just doing a quick revision. In point of care, we never, ever, ever use the word something's normal. As we all know, I'm just doing a revision for Fusic part before we get to Fusic HD. We never use the word normal. We never use the word abnormal in point of care, because that requires a full interrogation to say something's normal. All you're doing in point of care is you're looking to see the here and now, what you can see. Is the LV squeezing? Doesn't mean it's normal because it hasn't been interrogated. Is the mitral valve opening? Yes or no, doesn't mean it's normal or abnormal. It's just the here and now, what you can see. Okay, so that's just going back to the very basics. And then we look at pathology. So this is where our masses come in. So see, we're way down through the analysis before we should even be focusing on masses. Pathology is the last thing you look at for every image that you do in point of care or echo. It's anything in, on, or around the heart. Now, most of these pathologies will be anything in the heart or anything on the heart. So it'll be something sitting on a valve. It'll be something sitting within a chamber. Okay, basically, if you want to make it simple, what's not meant to be there? So if we look at this, we go size, right or left, thickness, old or new, function, is it doing what it's meant to do, pathology, what's not meant to be there. Okay, but it's the last thing that you focus on. Now I'm just going to show you back so that we just do a bit of revision. This is what the heart does. This is how the heart functions. I love this animation because it really gives you an idea of everything the heart's doing to the very, very tiny thing we look at in echo. And then we see our bean and see the heart. You can see it shortening, you can see it twisting, and you can see it moving. And then we get to this very simple picture, and then we're busy trying to make assumptions on what the heart's doing in this very, very small, rudimentary 2D image. So that just gives you a bit of a basics, going back to the basics, just showing you what the heart does. Now, what I'm going to go through now is I'm just going to give you this massive slide. You don't need to know it all, but these are some of all the newer, mostly used cardiotoxic agents and what they do. As you can see at the top, the anthracyclines are the ones that are dose dependent. They cause this cardiomyopathy, and it's very low cause, but once you get to the higher doses, it gets to a higher cause. But as you can see, there's a whole lot of other ones now that can cause some sort of different types of cardiotoxic effects. Now, this slide's more just for your reference as opposed to me going through the entire slide. The one we're going to focus on mostly at the moment is the checkpoint inhibitors, because they're going to be the ones that can cause or slip you up in ICU. They're the ones that cause myocarditis. Okay, so I'll just quickly duck through a few slides here. These are the ones that cause cardiomyopathy. These are the ones that cause pulmonary hypertension. These are the ones that cause heart valve abnormalities. And these are the ones that can cause arrhythmias. Okay, most of these probably won't get through to you in ICU, and it won't be something that you'll find without it already being known. But, you know, it's good to know who they are, and what they're going to do and what they can do. Okay, this is what can happen. So cumulative doses are the bigger problems, the ones that have to go through forward to say the more of it gives a worse effect. But then you can have other doses like Herceptin therapy. That's not the more you have, the worse it gets. That is really random. So we've got to sort of know the dose and be a doctor and know exactly what it is and who, or the dose and the drug, what they've had, when they had it, and what's causing it. The other one, which I'm not going to go through today, is this mediastinal radiation. Now, obviously, a lot of left-sided breast cancers will have mediastinal radiation. It is relatively targeted now, and they do CTs to try and miss the coronary arteries, but they cannot miss the scatter that does affect the myocardium. Now, this may not come up for 10 years, and it usually does take 10 years to happen. So that is something that you can look back forward and say, oh, wow, this young lady that's 55, she seems to have LV dysfunction. Why does she have LV dysfunction? We can't seem to work it out in ICU. It's really affecting the doses of, pressors that we're going to try and give her. And maybe she actually just has a really thick and stiff heart because she had mediastinal radiation 10 years ago. Once again, be a doctor. What I'm going to focus on today is myocarditis. So myocarditis is after the drugs that you have. It could be for melanoma, immunotherapy, checkpoint inhibitors. It usually comes on 5 to 6 weeks later. It doesn't come on 5 to 10 years later. It's 5 to 6 weeks. It's also usually not acute, so it doesn't happen a couple of days after the dose. So this is the one that you want to look at. So what we want to look at is once a patient comes in, if they seem to have some problem with their LV or their LV is not responding. Now, the thing with myocarditis, it's a little bit sneaky. Sometimes it's still in the type B failure where you can only see it on global longitudinal strain or an MRI, but the LV still appears normal. So that's when you'd have to say, okay, my patient's not responding. They've been on a checkpoint inhibitor. They've been on immunotherapy or one of the melanoma drugs, which we have a lot of in Australia, but maybe not as much in the UK. And it was at 5 or 6 weeks ago they had it. Okay, maybe we need to get this patient a strain echo or an MRI to see if the fact that there is some problem, myocardial problem, coming forward through into, and that's something that you have to look at in ICU. Now, this is something that can trip you up in ICU because you can see the LV and you think it's normal, they could still have type B heart failure, which will cause problems when the patient is at stress. Okay, this is a list of your checkpoint inhibitors that I'm talking about, the PD-1s, PD-L1s, and the CTLA-4s. So you can just photograph this or screenshot it, or I'll give my slides to to you guys. These are the ones you just want to keep your brain in thought of. These are the ones that are causing the problems at the moment. These are the ones that we're using more often. Now, remember that this isn't necessarily dose dependent, so we do have to be a bit careful of that as well. Okay, what I'm talking about with strains, I'm going to show you this. So this is strain. We're looking at the strain down the bottom. What we're looking at is the deformation of the muscle within the heart, similar to tapsiomapsy, to be honest. That's what we're looking at. But it's the tapsiomapsy if we're looking at not the annulus, but we're looking at a dot within the myocardium. Okay. At the moment, it is very myocardial dependent and not epi or endocardial dependent, although there are some newer things coming through where you can do layered strain. Okay. What I'm trying to bring forward here, though, I'll go through what strain is in a bit of a minute. The main thing I want you to look at here is the number. So this number, this global longitudinal strain, speckled tracking, I think it is with GE, they all have different names. This particular number, this negative number, the amount of deformation that it has, the smaller the number, so the higher the number. So if it's minus 21, it's probably normal. If it's minus 7, it's probably not. Okay, but this number is translational. So if you have a patient come in and you feel that something is bad, doing strain on them, especially LV strain and RV strain, to be honest, isn't really going to help you unless you know the strain before. Okay, so let me go through that again. Global longitudinal strain is a translational measure. It is not a here and now. It is not a here it is, this is the number, it is reduced. Okay, you've got to know what it was doing before, what it was doing 6 weeks ago, what it was doing 3 weeks ago, what it was doing a year ago. So then you're going to have to be a doctor once again, go searching for it and look for that number. Okay, RV strain is becoming a little bit more popular, very, very hard to do unless you've got absolutely beautiful images. And at this stage, I would probably leave that to your physiologists. Even myself gets it wrong probably 3 times out of 10 because of the difficulty in doing this. It does look simple. The software will give you numbers, but it won't necessarily be accurate. So once again, this global longitudinal strain that we're doing, which I'm going to go through here, of what it actually is longitudinal. So it's telling you what it's not telling you exactly what's happening now. This is abnormal. It's actually looking at it's happened before. We're looking backwards. We're trying to add it all up. We might look at it again in 6 weeks and see if it's changed or if it's any different. So you've got to make sure that you do go looking for those numbers. If you can't find those numbers, then don't use it as a here and now auto thing that can give you a yes or no answer. Just going to go through a bit of strain and speckle tracking, what it's actually measuring. So as you can see here, it's basically measuring the muscle fiber and how short it gets. So think of MAPSI or TAPSI, which I don't use either, but it's basically just looking at how a muscle increases or decreases. So just like a TAPSI or MAPSI, is it moving up or is it moving down towards the probe? Once again, remember, strain is load dependent. Just like ejection fraction, just like stroke volume, it is load dependent. It's not load exclusive. So if the patient is got a blood pressure of 85 systolic now, the strain will be different if the blood pressure is 120 systolic. Keep that in mind as well. We also have these more fancy ones where we have radial and circumferential strain. These are still very much in the research domain, but are being used more and more, mainly with athletes at the moment, and also looking at some sort of changes with subarachnoid hemorrhages because of the segmental nature. But this is all in the research. This is what we're looking for here. Different types of strain techniques. So it's all called very, very different things. It can be done on CMR and it can also be done on transthoracic. It can be done on toe, but it's not really lined up. The LV function is not really a thing that can be assessed on toe. So we tend to keep it in the transthoracic world, but it is becoming much more popular in the CMR world. In Australia, the CMRs are very expensive. We don't use them very much, but I do know in Europe that they are rebated. So people are using it more and more. The one that if you ever want to learn what strain is go and find on YouTube the ones that are doing velocity vector imaging. Okay, I couldn't find one that's moving, but the velocity vector imaging is basically looking at what that pixel is doing over time. You can see it with this because it'll go blue and red. You can see it with this, the speckle tracking, because it'll look as if it moves in the segments. The tissue Doppler is also a type of strain because we're looking at a movement within the colour once again. But most people's eyes aren't attuned to this. If you do a lot of echo every day, all day, you may have your eyes attuned to this. This is seeing absolute dot movement over time. So if you want to go and look up what strain actually is and what it's measuring, look up velocity vector imaging. Okay, there's lots of them on YouTube. A lot of the softwares do it. The older Philips machine, if you turn on strain, it'll have vector imaging. They've turned it off on the newer ones because they think now that we're used to seeing it, so we don't need it. But this is how we learned how to determine what we're looking at with strain and what it is actually that we're looking for. Okay, so I'm just going to go quickly through strain and oncology. So what we're looking at here, yes, the LV is dysfunctional. And then we're going to look down at these numbers. Global longitudinal strain, this is GE, so it calls it global strain. They're all very different names, which is a bit frustrating. But what we're looking at here is the dot movement over here and the fractional, and the shortening between the apex and the annulus is what we're trying to look at. We have to look at it in different planes, and we have to have the plane. So this, to do strain, this is what I sort of want to show you here, is this length from here to here, so from the annulus to the apex, has to be exactly the same to the millimeter, just like Simpsons, but even more so as every image that you measure strain from to make a global longitudinal strain. So that's really important. So if you want to sort of muck around with strain in your ICU, make sure that you can get your apical 4 images absolutely exact, so that this to here is exactly to the millimeter, the same length of every other, the apical 2 and the apical 3. If it's less than or more than, you have to go back and do the whole 3 again. Okay, so that's just trying to show you how complicated it is, but it does actually give you a measure. So this measure is quite low, -7. This LV looks relatively poor, probably moderate, maybe mild to moderate dysfunction. And what I'm trying to show here, though, is that we have to ignore what the function's doing and just look at the strain. Or we ignore what the strain's doing and just look at the chamber reduction. Or we ignore what the strain and the chamber reduction is doing and we look at the wall augmentation, which are the 3 different ways that you could look and see what the ventricles are doing. So this is trying to give you a bit of an idea of actually what it is that you have to look for, but also what you have to look for in the echocardiography reports, also what you may want to ask for. If the patients are coming up, you may say, look, we've got this patient, they haven't seen a cardiologist for 3 years, they've had have Herceptin therapy, could we possibly get strain on this patient? And then you can ask your physiologist to make sure they do that. So when it goes back down to the cardiology lab, you can actually then find out that sort of information. Or you may want a CMR to see if myocarditis has come on because 6 weeks ago they had some immunotherapy, and you want to see if that's what's causing the problem in ICU because you can't get their LV or their stroke volume to increase with pressors. Okay, so I just want to go through a quick little things with the strain and oncology follow-up. So this is how patients are followed up. So we always do baselines with strain, and we also look at all oncology patients with baseline, and we do them at 3 months, 6 months, 12 months, every 6 months for 3 years, and then we do 5 years and 10 years post-treatment. These patients are heavily monitored. Okay, they rarely can slip through cracks. Now this is worldwide. This is not dependent on different countries. So this is what is standard now. And but what we want to know is it's a very early predictor of later reductions in EF. So if the strain is slowly reducing over time, then we can maybe think that the EF will slowly reduce, and there is some evidence that there could be some cardiotoxicity within the patient. Okay, now I'm going to just move a little bit onto myocarditis because this is what you're going to sort of trip you up within the ICU. Is we want to look at myocarditis and the immunotherapies that we're using, because traditionally you'd want an echo to have a look at the LV function, but if you think the patient has myocarditis, obviously we're going for MRI strain echo. The one to watch is the immunotherapy regimes, the melanoma regimes, or any of the newer agents with NAB at the end, if you want to make it simple. And it's not the anthracyclines that are going to be your worst enemy now going forward within ICU, or what are causing the LV problems post-cardiac both post-oncology regimes anymore. Okay, so that's just a bit of a summary. And once again, this has now been a statement that's been released that oncology-induced heart failure will be the biggest percentage of heart failure in the population within the next 5 to 10 years. So we have to keep it in the back of our mind all the time, but we also have to not overdiagnose it or blame oncology for everything we see wrong with the heart, which we probably did before, and maybe it wasn't warranted. Okay, so this is just a case study that I'm quickly going to go through. So Northern Territory, Central Australia, we're in the desert. So we had a 58-year-old patient, fits, works on property, had METs, now in her 7th year, presented for an echo, short of breath, tired, new GP, ejection fraction was 20%. Now, this is something that could end up in an ICU. You look at a patient, ejection fraction is 20%. Now, you can't blame the anthracycline. We don't know what caused it because there's no baseline, or they couldn't find a baseline. So that's why it's really important in the NHS. It's much easier to find your baselines. You need to go back and find baselines, or you need to go back and find the previous echo to see if it's these anthracyclines or if it's oncology agents causing the problem, and not to blame the problem, not to blame the oncology agents. Okay, now I'm going to go through masses. So now we've moved on to the oncology. So I'm just going to step out of this for a second, just go back to the other screen. So now what I'm going to go through is masses. Now, a lot of this I'm just sort of putting up so I can share the slides and you can sort of go back through it. But I'm just going to go through some of the basic cardiac masses and ones that you have to worry about and ones that you don't have to worry about. So these are the different types of the masses, and there's this is the different sort of interventions that we'll do, and then some of the things we won't even bother about doing. Okay, these are the classifications of the masses. So we have cardiac tumors, primary, secondary, benign, malignant. We have vegetations, introgenic material, normal variants, which there are a hell of a lot of. Extracardiac structures like cysts in pericardiums, and obviously then thrombosis. Okay, so these are some of the complications of the tumours, which means that in your world, you'll probably see the complication before you actually see the mass, because they may get to ICU before they've even had an echo. And some of them may know. So sometimes the patient will know they had something in the heart, is usually the word cell used. Mind you, they do use some other sort of words. They'll say something was in the heart and it's not there now. And that could mean anything. So we're, as you know, I'm not telling you medicine, but arrhythmias, valve dysfunction, cardiac chamber obliteration in CTs and MRIs, compression, embolization, fusion tamponade constriction. That's very much a clinical world. Chest pain, heart failure. So these are the things that the cardiac tumours or masses can cause. So then what do they actually look at? So what we want to do is we want to follow echo principles, because that's what we're doing today. Is an echo can't tell you exactly what the mass is, no matter where it is, what it looks like, or what is happening. It can give you an idea with a few tips and tricks, but at the end of the day, you do need biopsies, and you do need to know the history of the patient, and you do need to have histopathology done. So even though I will say a few things here to say this is consistent with what a melanoma looks like, this is consistent with what a myxoma looks like, you actually can't diagnose it from an echo. You can't diagnose it from pretty much any imaging, even the MRI, which is more sensitive. It's still very hard to diagnose the difference between a tumour and a thickened thrombus, such as a portocath thrombus. Thrombus vegetations are always your most likely, so always go down there. We're not looking for zebras. Cardiac tumours are secondary, and then primary cardiac tumours, so myxomas, pericardial tumours, fibroblastomas, all those things, they are the most benign and the most rare. So try and sort of keep that in mind when you're looking for the shiny objects that come through. Okay, so I'm just going to do a quick case study. So this is something that you may commonly see, actually, and you've got to be very careful of, because you do not want to remove this line. Okay, so not 651, just 51-year-old female. She's currently HER2 regime. She has a portocath in. The portocath is sitting slightly within the RA, probably a little bit too far, but the radiologists aren't going to remove it. We're having regular imaging for her cardiac toxicity because she's on HER2 therapy. And we're going to have an interrogation of the heart every time. We're not just going to look at the LV. So then I'm going to go through this. Okay, so this is what a portocath thrombus looks like. Okay, so this is when we're looking at the where. Okay, the portocath is going to come through here. Okay, it's going to lie along the septum, or it's going to curl itself around that way, or it's going to come through this way, depending on where they're putting it. Okay, some of them will put it from the SVC, which we hope they do. Some of them put it from the IVC. Some of them put it from the arm. Basically, it'll end up somewhere in the RA, or the the RA border is where it's meant to sit, but we know that these lines do move further in, and we do know that people who have cancer are more thrombogenic. So what we have to look for is, this is what a portacath tumor will look like. It'll look like it's attached to something in the heart, okay, not the actual portacath. It won't swim around. It won't swim around the RA because it'll be quite thick and heavy by then. And remember, this is upside down. So the portacath is coming and it's going down, so it's just sitting somewhere. It'll try and rest on something, okay? Thrombosis are also very sticky, okay? Now, this doesn't mean the portacath doesn't work. So it won't necessarily be obstructed, okay? So this is what they look like. They look like a lollipop with a little top on end. It doesn't usually move around the heart. It'll usually stick itself onto something, and then the portacath will also stick there because it is quite loose. Okay. Now, the other place it can sit is if they are sitting down near the RA border, here, RA SVC border, what they'll sit is they'll just sit here, and they'll look like little like flowers growing in the garden. They just look like this. Can everyone see my little hand on the screen? You can, I'm hoping.
Yeah, we can see it.
Oh, you can, cool. So just yeah, so they'll sit like here, and then there, and then there, and they just keep massing along. And that's when the portacath is sitting a little bit further back. Now, these necessarily aren't that uncommon. Now, what happens is these catheters get pulled out, and obviously those clots are too big, and then they're going to end up somewhere else where we don't want them. This is quite a big one. They can also look like this. See the little tiny one here? This is another one that's developing. This is a developing clot, different patient. But as you can see, the heart's all working perfectly fine. As we know, as clinicians, clots do not sit on moving objects within the heart. So they do not sit on LV walls at work. They do not sit on RV walls at work. They do hang out in left atrial appendages, but they do tend to get on top of these portacaths. Okay, this isn't necessarily the catheters that you guys are putting in, because the flow is probably a little bit faster and more regular, but it is for the oncology patients. So it is something to keep in mind. It is something that you could just go look for, especially if you've got people who are training to do FUSIC, make them go and look at these people just to have a little peek. But this is what a developing clot looks like. See how it's a little bit more mobile, and it's also slowly starting to stick onto something. I don't know if it's going to stick onto this eustachian ridge, or whether it's going to stick onto this annulus of the tricuspid valve. But this is where, or what you can see with portacath clots. Okay, these have to be reduced with I don't know, whatever sort of antiplatelet or anti-therapy you want to use. This particular patient here was resistant to a lot of things and had to go on warfarin, which obviously isn't a great thing for someone that's on chemotherapy. Okay, and then this one here had a different type of therapy, but eventually it did reduce. Then the portacaths are removed. That patient then is actually marked to not have another portacath. That's another thing you could look at in ICU for your trainees, is to make sure you've gone back and looked, and if they have had a clot before, is it really the risk of putting something into the RA? Okay, so then we're going to move down to another one. This is a 6-year-old male, previous BCC removed from the skin, recurrence of lesions in the right lung, echo, pre-chemotherapy check. We did do a CT. There was a bit of a lack of contrast in filling in the RV. This is not uncommon due to the flow and due to the way that the contrast goes down into the RV, or where it's being put through, whether it's being put through the femoral, whether it's being put through the brachial artery, or sorry, the brachial vein. And they also had noticed on an MRI that there was a 7-centimeter mass infiltrating into the myocardium. Okay, now that was just separate to what's being found. And then this is the standard routine echo that was done. Now, if a patient has a 7-centimeter infiltrating thing into the myocardium and it's not within the chamber, which is not what they saw, then this could be something that you find in ICU. Now, this patient was an outpatient. There was the patient, see, there's no clinical reason that the patient was having an echo. They were just doing it pre-chemo, but this was what was found. Now, this is a melanoma. Now, melanomas look like cauliflower. Now, once again, we can't diagnose that completely, but melanomas tend to look like cauliflower, and they're multilobular. Okay, so this is a melanoma sitting within the RV. Now, I'll ask a question and you probably won't answer, but why would it sit in the RV as opposed to somewhere else? The reason it's going to sit in the RV is because melanoma is an incredibly smart disease. The melanoma isn't like other types of masses and oncology pathologies. Melanoma does not block off its own blood supply. So the melanoma will rarely sit in the atrium, because guess what? That's where its blood supply comes from. So the melanomas will sit around PAs. They will sit around things and have their own blood supply. They tend to not create their own blood supply like, say, some other masses. They just use the blood supply coming in. So this is why the melanomas tend to sit here, or they sit in the LV. Now I'm going to tell you something that a cardiothoracic surgeon told me one day when I was telling him about this patient. He said melanomas are the most common mass found in autopsy. How's that? So that's worldwide. That's not just in Australia. So basically, they are so intelligent. This pathology is the fact that it doesn't block off its own blood supply. So it'll sit here. It won't block off the tricuspid valve. So this patient is actually coping with this mass. And once again, we don't follow the shiny objects. But what it's doing is it's taking its IVC and SVC and it's getting its blood supply. It's locked itself in here. And as you can see around it, there's all this blood supply moving around. And also the blood supply can come through here. And also you can see the RV is not dilating because it isn't causing any increase in pressure. So this is just an example of one of the masses that can be very elusive to any clinical diagnosis. But this is something that you could see. Something like this, you would obviously go for cardiology straight away. They don't necessarily need to be cut out yet. They do respond quite well to immunotherapy. And then you would go down that road. But as you can see, it's not increasing, and no size is increased here. The function of the RV seems to still be working. So every clinical assessment would not find this mass. Okay. And we're going to look at a few primary benign tumours. So about 90% or so are all these tumours that come and end up in the heart that don't really cause issues. They're usually quite small. So I'm going to go through a few of these. I'll just quickly whip through just for time. This is the most common one, usually within the LA. Sometimes you get it in RA and RVLV, but mostly within the LA. They always usually have a stalk, and they usually are by themselves. Okay, this is what they look like in histology. They're kind of like little bally masses. And then these are I don't know the clinical symptoms, but this is what they look like in echo. So as you can see, this looks pretty different to the one we just saw, because the one we just saw looked like a cauliflower and a bit more like a hand, whereas this one is a ball, and it has a stalk. Now, don't be confused and don't be scared. People live with these for a very, very long time. They can also go out there and come back in, and the patient actually doesn't have any symptoms. Maybe they have a bit of SVT, tiny little bit of arrhythmia, but they don't have any shortness of breath. So these are the sort of things that you don't chase for shiny objects. You continue your bedside cardiac exam, get all the images you need to do, then work out what the question is you were trying to answer. And this is your incidental pathology, that very, very last thing that you look at. Okay, and then you forward this on to cardiology, and then they will start dealing with this and work out what they want to do, whether they're going to leave it there for a period of time or whether they're going to look at maybe cutting it out. Okay, but this is kind of what a myxoma looks like. They are more commonly in the RA. I have seen probably one in the LA. I have seen one in the RA in my life. I've never seen a ventricular one in all of my scanning. They will have a stalk. The stalk here is sitting down here. Sometimes the stalk can be a little bit hard to see. Okay, then we measure them, and we measure them over time because they may or may not get bigger. They may just sit there. And then we can also do fancy things like contrast to see if there's a lack of contrast ending up within that area to say that that is a mass and not a artifact. Okay, then we're going to go for primary fibroelastomas. Now, these ones, we find a lot of these. These ones are the ones that you see the most, the ones that are sitting on the aortic valve. They're not excretion glandules. They're like little tiny masses, and I'm just going to go through these. They don't tend to break off. They don't tend to cause vegetations. They kind of just sit there. The only other place that they can sit maybe is sitting on the left ventricular band. So as we know, there's 2 or 3 left ventricular bands in the apex, which is one of our landmarks that we know we're in the apex. Then they also can sit on some of the left ventricular bands that go from the base of the septum to the apex, and then also the bands that may go from the posterior medial pap muscle to the septum. So these are what fibroelastomas look like. They're kind of like these little movie little masses here. If the patient isn't febrile and the patient isn't unwell, then don't go running down the road that this is endocarditis. We do have this problem that people see something, and even though the patient's not febrile, everyone's running around thinking it's endocarditis. So just be careful on what you call, because it can cause more problems for the echocardiography department. Just note what you've seen, show the images to a cardiologist or an imaging cardiologist, and move on from there. Okay, these also don't necessarily cause regurgitation like endocarditis does cause regurgitation, because it's distorting the valve. These have developed over a very slow period of time, so therefore the valve is not distorting. Okay, here's another one, just like one of the things I see. So this is another fibroelastoma. This is looking at it on a toe, but this is, once again, it's just a little ball that's sitting on one of the leaflets, and it's not distorting the valve. Okay, this is what they look like when they cut them out, or whether they don't cut them out. Sometimes they just leave them there. Okay, the last one I sort of want to look at is this lipomatous septum. So I get all of my echo people to look for lipomatous septums. So lipomatous septums are relatively rare, but what happens is in the short axis or the skeleton view of the aortic valve, which is one of the views we get for point of care, I always make my trainees in intensive care to look for a thickened or lipomatous septum, because it can mean other things. So it can just mean fat deposits, it can mean infiltrate, or it can mean other things going forward, like something ischemia. It can mean that diabetes is coming on. So what we like to do is just make sure we look for this. So this is an MRI, but I'm just going to go through if we can see one there. So basically they just look like these little fat little blobs. Okay, this is not necessarily a patent, this foramen ovale. So what I want to do is, one of the things that I make all of my intensive care doctors look at once they become slightly more intermediate is the interatrial septum fattening, because it can just mean other things. And so it's something that should be put forward, and it can also stop you being able to diagnose things. So if it is fattened and thickened like this, it no longer will move into the LA or move into the RA in times of extreme pressure on one side or the other. So you've got to keep that in mind as well. Okay, they're clinical features. You don't really need to know that. And the last one I'm just going to quickly here is rhabdomyeloma. So rhabdomyeloma, lymphoma, things like that are all these growths that end up everywhere within the heart. Now, these growths come and go. These are weird. I see them in the heart, and then 3 weeks later, they're gone. This is something that you do probably need to call oncology to come up and sort of deal with, but these are funny things. They can look horrendous in your echo. They can look terrible. They look as if they fill up all the chambers. They look everywhere. There can be 20 or 30 of them, and then a week later, they're gone. So this is just something that, yeah, if you see this, multiple small balls everywhere, that's obviously then just refer that on to oncology and get cardiology involved, because they don't usually cut them out, but they do have to do something about them. Okay, because these ones are a bit nasty, and they can embolize. They can be, but then they can just disappear as well. So the last one is, I want to just quickly go through here, this is a slide I really like to look at. So benign and malignant tumors. So sarcoma, metastatic tumor, renal cell is a really common one. Uterine cancers, they come up through the IVC. I don't know if you've ever seen, there's masses that you see come up through the IVC and they end up in the RA, or you see a mass moving within the IVC. These are usually going to be uterine, ovarian, or renal cell carcinoma. Now, this can be an incidental finding. Okay, this can be an unknown disease, and you see a mass moving quite solidly within the IVC when you're doing your IVC assessment. This, then you need to call your friends, phone a friend, because this can be undiagnosed, and I have seen many of them. Okay, then we've either got the metastatic ones, then we've got the lymphoma, melanoma type ones. They're more within the muscle, or they can just develop their own thing using their own blood supply. Myxomas always have a stalk. Papilloma, fibroblastomas always sitting on some sort of valve somewhere. Okay, extracardiac tumors usually going to sit in the pericardium, and that'll be we either have a pericardial cyst. Now, pericardial cysts, you do need to have them checked at least once. They're not a massive problem, but they can grow very fast, or they can just stay the same size forever. I've had a patient who had a 3 centimetre one. 2 years later, it was 15 centimetres. I've had other ones that have had 10 centimetre ones and have stayed 10 centimetres for 20 years. So that is the cysts. The sarcomas, or the tumours that end up in the pericardium, they are nasty. So if you see them, obviously phone a friend of your other specialties. And then hiatal hernia, that's just one I wanted to bring up. That's not really a tumor, but that's when you see a big mass in the forechamber of the LA and you're lined up all of your things. You've got your right upper pulmonary vein, so you know you have the forechamber. As we all know, you don't have the forechamber unless you have the right upper pulmonary vein within your picture. If you see this big mass, you can't get rid of it. I do the Coke test. In America, they call it the soda test. Get them to drink something that's fizzy. If this, then you can see all the bubbles going through it, it's a hiatal hernia. If you can't see bubbles go through it, once again, phone a friend and move into your other specialties. So that's pretty much what I've got today. And that was just the melanoma showing here. That's pretty much what I've got for you today. So just going through it again, thrombus and vegetations are usually our most common. Cardiac tumours and secondary are next most common. Primary cardiac tumours are really uncommon and usually benign. But once again, be a doctor, get your clinical information, get your past history, and then work it out from there. Okay, so that's pretty much me for today. And I kind of hope that's given you a bit of an overview of everything to do with cardiac toxicity and masses. It's not perfect. There's a whole lot of other things that we can do, but they're the things that are probably what you'll find in ICU.